Well, folks, welcome to our June edition of our Valuation Lab chat series. I'm joined here by my wonderful co-host, Tom Gunderson, looking slightly more sporty in his co-host chair than before.
Pacific Northwest, sorry.
There you go, but still near a dock somewhere. I mean, yes. So as you know, we've transitioned to our dockside part of this, and so we're thrilled to have a fabulous chat today on AI and analytics in healthcare. Three wonderful panelists that probably, in some respects, Tom and I are probably just going to stand back a little bit, but we'll stop some of the conversation in a little bit. So Susan Alpert, I think everybody knows Susan. Susan has just a distinguished career in all that she does for the FDA and in private industry. She has her own consulting shop and has been our founding executive resident at the Medical Industry Leadership Institute, and can't thank her enough. Bill Betten, Director of Solutions for S3 Connected Health, and then Julie Kemp, another one of our great EIRs, Senior Director of Marketing at Philips and a longtime supporter. So part of why we do this is just to have some really fabulous conversations. This will be recorded, the first 30 minutes. We are on the record, and then we're sticking on for another 30 minutes to go off the record as conversations proceed. With the recordings, people might realize that these things get used a lot by other people in other classes, not just at the Carlson School, but other universities as well. We're kind of going wide. Of course, if anyone has fabulous students or colleagues that want to have a fabulous medical education, whether certificate or degree, please, by all means, send them to the Carlson School of Management. And with that, I'm going to hand the baton over to my most enlightened co-host, Tom Gunderson, to kick us off.
Great. Thanks, Steve. And thanks again for the panelists that are going to discuss AI. And, you can't pick up a newspaper or read anything online that on any given day that's not talking about ChatGPT or AI or advanced analysis, et cetera. We're going to look at this, but as I was mentioning to the panelists earlier, we can talk about it sort of esoterically. We can talk about it for the future, which I think would be a good part of our conversation. We can talk about what we're doing now as far as decision making with better data analysis available to us because of the tremendous computer power that's come forth in the last couple of years. And we can also talk about what this might mean for clinical outcomes. Can this change? Can these analyses change clinical practice in the near term? And what are the pros and cons to that? So with that, maybe I've known Susan the longest, so I'm going to start with you, Susan, and say, why don't you just give us a couple of opening thoughts, and this will be more of a conversation on AI and healthcare and medtech than a dissertation.
Hopefully I can do that. So hope you all put up with the mixed messages that we're actually in the middle of with AI. So you all know that I used to be the FDA and I do a lot of regulatory work. So I do look at it from that perspective, but I'm also a clinician. And when I look at what's going on with AI, I also look at it with my clinician eye, with what would I do in practice? How would it influence me as a clinician? Where are the pluses and where are the minuses? So I think we can start with thinking that, AI is a capability that will help medicine a lot. Because if you think about the volumes and volumes of data that are being developed about patients, particularly the very sick ones, but even us healthy people, like I go to Mayo Clinic for my annual physical and I get, 20 blood tests and x-rays and ultrasounds. And if I have something, I wind up getting even more testing. And the idea of being able to manage that in a way that is informative for my clinician, but also accurately about me. That's sort of the challenge that we're dealing with, because if AI deals with large numbers, the goal is to have a lot of data and to have that data be able to use that data to mine and find find important aspects or important patterns, whether it's for the diagnosis of a disease or a treatment pattern or a response to a treatment or whatever. That's challenging, and being able to pull that together and make it applicable to everybody is the real challenge. Because if you think about AI being live and that all the new data coming in influences the answer, whether it's for a test or a diagnosis, well, it depends whose data is coming in. If a bunch, let's take it as a diagnostic. Let's say we have a great diagnostic for type 2 diabetes. And we're continuing to grow that database and use AI to identify who the patients are that need to be treated or further evaluated or get intervention about their diet or their exercise or whatever. Well, it depends who the next group of patients coming in is and what they had that can influence the AI, because it's an algorithm. It's not, if it's an algorithm and it's constantly changing and moving, then the input data affects it. So that, as both as a clinician, I'm a little concerned about. As a regulator, I can tell you that that's why AI is not more prevalent in all of medicine. It's quite prevalent in certain areas, the lab and radiology, where you get the real data on that patient and you can make decisions. There's still a decision maker, but AI in other places a little bit more scary. So I'm going to stop there. So from the regulatory point of view, we're not ready yet. FDA's things, they've written some very interesting guidance documents about how to use AI now, and the fact that we can't let it run things because they say Congress needs to write new law. We're going to talk about that because I don't think that that's exactly right. But so we have an environment where there's almost 200 devices that have been cleared that have AI in them or machine learning in them that have influenced the development of those devices. And Julie can talk about that because Philips has some of them. But they're not standalone. There's a few that are diagnostic, a lot in radiology. The radiologist is still there. So those are just some of the high points from my perspective, both as a clinician and as a regulator, that AI is great. It's going to be a wonderful tool, but we're not quite there yet.
Julie or Bill, Susan's outlined from a regulatory standpoint, a clinician standpoint. Why don't we get a little bit into the industry side of this and how you see industry looking at AI going forward?
Sure, I can start, and then I'll have Bill do, since he was on the PAC side for quite a while. I'll have him kind of focus on the radiology side of it, because radiology has been using it for many years in different forms, and whether they knew it or not actually at the beginning. But for me, from an industry standpoint, there's absolutely the opportunity to build in AI. We do it a lot, like we said, in radiology, but also in patient monitoring, because you have a lot of data coming in about patients, and particularly if they're in critical care, they're getting all this data coming in from maybe 20 pieces of equipment, all the data, and it's hard for physicians and nurses to be able to connect the dots. The nurses are taking care of the patient. They're not watching the monitor. They're not watching the ventilator. They're not kind of connecting the dots the way in which they need to from a data standpoint. And so AI can be a huge benefit to like critical care nurses and intensivists for being able to point out, patients that could be at risk of deteriorating, and when they deteriorate very quickly. And so it could be everything's just fine at kind of a subclinical level, and then things go south very, very fast. So that's really kind of one of the areas of AI in industry. But I think the challenge really isn't the ability to put AI into the different type of hardware and software and build it in. It's really the adoption. And you aren't going to get AI to be adopted by clinicians unless you put it into their workflow, and unless it becomes part of that workflow and they don't have to do extra steps to make it happen. So from an industry standpoint, that's our focus, is really how do you, not just doing the AI but how do you build it in so that they don't have to do any extra steps? It's there, it's kind of running in the background. And they don't have to think about it. And with that, I'll switch over to Bill so he can talk about the radiology side and other things.
Well, I'm going to tackle a little bit more than the radiology just for a second, because I'm a techie and I've been doing this forever. I'm a double E and a physicist, and I focus on technology and building products. And we're in the 4th or 5th generation of AI. I still have my neural nets textbook from the early 1980s when I was working with DARPA on intelligent transportation and self-driving cars and things like that. So later in the 90s, it was called big data, or no, it's called visualization first. It was neural nets, then visualization in the 80s and 90s. We're going to visualize this. Then we had the world of big data, little data, and now AI and ML are the buzzwords that have, if you don't have that in your product, you obviously can't attract an investor. So I'm going to hit it from the technology side a little bit, because for many, many years, technology was lagging and we weren't able to do things too directly. Now, in the 80s and 90s, PACS came around where we could now beam images, send images all over, and start dealing with those. And radiology was an early adapter of image processing technology that actually came out of the military, because it was good at looking at patterns and analyzing things, identifying things. And as Susan mentioned in our previous conversation earlier, a doctor was always in the loop, a radiologist in the loop. Numbers I got from the FDA as of July, they had 521 AI/ML cleared applications, with over 400 of those in radiology. And we could debate which ones they are and how well they work and what they do, but there's certainly a lot of attention being paid to it. At the end of the day, it's about crunching numbers, as Susan mentioned, I think, and it's about developing algorithms and processes and things that will go through that data and look at it. I'm an old remote monitoring guy as well, and Julie mentioned some of that. There isn't a clinician in the world who wants my heart ECG 24/7, 365 at all. I've been an early adopter of the AliveCore cardia wearable because I knew the people involved in that. And it's fun to play with. It's fun to do things, but I guarantee that if I had a heart problem, which I unfortunately don't, they want to know about a half hour before I have a heart attack, so they can tell me to take an aspirin and call an ambulance, and they'll monitor me for 30 days afterwards because of regulatory requirements for reimbursement, readmission, that sort of thing. So nobody wants that information. They want to know, and I'm back to where Susan commented, it's event-driven decisions around what's happening there. So I can capture all the information in the world, mine it, do things with it, but until I turn it into something that's identifiable and actionable, it does me no good. It is a tool. We have issues around accuracy and training. I think we'll do a deeper dive into that. I believe in the technology. The technology is now here to do things that are both very positive and very dangerous. And the last piece I'll say is, we talked about getting it into clinical practice, but as a technology guy, I believe we've now created technologies that are incredibly useful, but until they change the infrastructure and the way in which we work, whether it's patient knowledge, whether it's reimbursement, whether it's physicians and how they practice and what's going on, it's no longer just a technology issue. It's a rip up and re-tear of the way we practice and pay for medicine. And I'll stop there.
I want to jump back in for a second, because I think, Bill, no, I think you hit on a couple of things that I think are really important. One is how is this maturing? So we talk about it as AI, but much of it is machine learning. It's not really AI. It's not artificial intelligence making decisions. It's machine learning. It's data aggregation, data analysis, and data being presented to inform, as opposed to constantly decide. There are some products that went into the market, but FDA has been really interesting. Bill, you talked about the number of products.
Yeah.
If you read what they say, they are enabled.
Yes.
They
yes.
are AI or ML enabled. They're not free form, functional, full independent decision-making algorithms. They are informed by machine learning. There's tools that are informed by AI and some of the things that cause change in algorithms. But they're not freestanding AI. There's a lot of misunderstanding in both the public as well as inside the medical community that we're not really at AI now. It's machine learning. And as Julie said, and as Bill said, it's managing data sets that we're collecting now to make some sense out of them, to put some order to them and try to make them useful tools. And I think those are some of the things, if you're an entrepreneur in the field, whether you're on the pharma side or on the med tech side, whether you're doing monitoring or you're doing diagnostic testing, whatever you're doing as entrepreneurs in your companies or in your projects, software and AI or ML is sort of there. It's a matter of how do we leverage it, and how do we understand what it's doing to the information that we're using, so that we still have some filtering and some control. Because frankly, one of my things is people are all different. People are all different, and if we were all the same and we all presented the same way and we all had the same kinds of journeys in disease, that'd be great. It ain't true. We're all individuals, and there are patterns, and that's what this stuff is really good for. There are patterns, but we all present a little different. We all have quirks, and whether it's our diet or our body composition or our age or our gender or all these things that influence all of our data. And so still, it's great and it's going to be wonderful, but we're not quite there yet to the individual level.
Yeah, it's definitely, to build on that, it's a lot of, machine learning is a lot of pattern recognition, a lot of predictive analytics. And so the more data you get, the more specific it starts to get. So the original applications and algorithms are based on a certain amount of data, but as you start getting more and more data to be able to work into that algorithm, the algorithm changes because it gets more data, and it sees different patterns emerging and more specialization, I guess, for lack of a better word, and then it can be more specific that way.
And I want to touch on that point, and it's been talked about a little bit, but again, as the product development folks, and as we think about it, growing up in the medical industry, you're trained as an engineer and a scientist, and when you build these products, that configuration management is incredibly important. That if you're going to change anything in that product, I get to at least send a letter to the FDA and explain why it's not changed its function. So the question of smart algorithms and learning algorithms is incredibly important. So we've been trained forever and ever to, you build a configuration, you test it, and that's what you launch. And boy, you don't change that. We had a revolution come about when we said, we're going to do over-the-air updates. We've had the capability to do that forever, but getting allowed to do it and change a configuration under very tightly controlled conditions made a huge difference for us in the technological world, because we could update, change, modify, and fix things. I'm working with a client right now that's a startup out of a big company, but they spun it out, and we're going to use AI machine learning to train the algorithm, to learn from the algorithm. We're going to gather the data, but you know what? We're going to freeze that algorithm, launch it. We're going to gather a lot more data as the clinical grows. I'm going to cycle it again. Every configuration that we launch is going to be known and tested, because that's pretty much what's required today. That's one application that's very real. Another one, though, a little bit different, we see in the pharma world, is people who want to mine the EMR information, look at it, and figure out, A, who can I sell drugs to? Because it is about money after all. Who can I sell those drugs to? And then B, does it help? Can we follow up? Does it do any good? So a couple of different applications there that are starting to use machine learning, but still under fairly tightly controlled conditions.
So I'm going to pick up on what you said, Bill, about FDA, because it's very interesting what happened. About 5 years ago, FDA wanted to be able to do stuff, and they thought that the best way to do this was to have companies tell them how they were developing the algorithms, and that if you got certified that you had a good development program, you could develop your ML, your AI, and not only put it in your products, but continue to change it. And they did a whole study on being able to do it the way we do quality systems, to say, if you have a really good software quality system, which is what it was, a software management program and a software updating program in your company, and you do it really well and you have all the controls in place, you could be certified to change your algorithms on your own. And they found out it didn't work. Didn't work. They couldn't get to that place because just having good tools wasn't quite enough, because the products are still changing. So what they've got now, that's important, but not standalone, not enough. So what they've done more recently is to say, what we want to see is, if you're going to bring us an algorithm, if you're developing an algorithm, machine learning or AI or both, and you're supporting an algorithm, bring that to us, but bring to us not just the way you develop it, the controls on the development, but bring to us what's the schedule on which you're going to evaluate it. What's the periodicity that where you're gonna reevaluate what it does and what it's done with data on known patients. So taking somebody who's already been through it, start with their early data and show that works, and have a schedule, a predictable time frame with triggers, so that FDA and the doctors can be assured that you're watching how much change there is. You're watching that the change is in the right direction, that it's getting better, not getting worse. So their new program is, okay, you can bring us AI-enabled technology of all sorts. It's in cardiovascular, and it's in neuro, and it's in radiology, and it's in diagnostics. But when you do that, you have to tell us on what schedule are you going to evaluate it? What are you going to be testing, so that we can be sure that there are controls in place, and we can look at them. We, the FDA, can look at them. So you'll send us these reports on this regular basis, so that there's multiple sets of eyes looking at what's changed, and how is it being assessed directionally, and understand, so the clinicians can be confident that if it's changed. Doctors are hard. I'll admit this, doctors are hard. You get trained to do something, and the way we're trained is see one, do one, teach one, and then you keep teaching. But you keep teaching sort of what you've done. So getting doctors to really change how they practice is not easy. And if they have skepticism about whether or not the tool is appropriately tested, they're not going to use it. So to Julie's point, there's not going to be a market, because people aren't going to buy it, because they're not going to use it, or the hospital's not going to buy it, or the system's not going to buy it, because they'd have to beat all their doctors over the head to use it. So building in the credibility in the system and providing the data that can be looked at in the public venue, in fact, in the summaries that are published, will enable companies to get the doctors to feel more confident more consistently. But it's a challenge. It's a challenge.
I want to throw a question out to the group because we're going to probably turn this off the record in a second. But so taking it out of the context of the tech piece, but one thing I've always heard about a recent term of art is this idea of the learning healthcare system, not machine learning, but it's the learning healthcare system. And so you think about, well, let's take that back to AI. It strikes me that if you're really going to have the learning healthcare system that is enabled, to use the term, by AI, it requires a very comprehensive and accessible electronic medical record that a machine learning algorithm can review and examine. So those are there's lots of ifs here, right?
Yeah.
Super ifs, yeah. I mean, and Bill, I remember all those algorithms and like all the language you were talking about in the 80s and 90s when I taught it too. And like, neural nets being like the wave of the future, which was just a fully specified logic gone wild. So, but basically, so here's my question though, it's like, so what's the gold standard of best practice? Because this is always, this goes back to a debate from the 80s and the 90s about, when clinical effectiveness research was put out and the federal agencies were behind it and everybody wanted to go to small area variations. But yet, on the one hand, one person's new innovation that's a gold standard of how to practice medicine could potentially be outside the norm, and the norm might actually be too old. So, I mean, so how does the system learn to know what to do and record what's going on, assuming the data is even there?
Well, one of the answers, some semi-facetiously, but it was interesting, and I spent a lot of time at Mass General in Georgetown in an earlier life, was the comment, you wait for the old doctors to die and the new ones to come in. Sorry, Susan, but yeah, I mean, there's some truth to that. It is an evolution, and I lived through the going from film that you put on a light box anywhere you wanted and transitioning to a screen, an old CRT first, and now flat panel displays where you're reading images anywhere in the world, was a huge transformation because people were used to looking at things on a piece of film. An interesting tidbit with that is more radiologists are colorblind than any other profession because it was one of the few medical professions where seeing color didn't matter in those days. So they could
dark and light.
Yep.
Dark and light.
Shades of
and
gray.
Circles.
Yeah.
And circle them.
Exactly.
It's changed so much though now. So
Yeah. So it is an evolutionary sort of thing. You have to fit it in. I can't tell you how many devices I've designed over the years and my teams have designed where it's make it work pretty much like the last one, A, because you want to have a precedent so you can get it approved, and B, if you change where the knobs, the dials, or what they expect to see, then you're changing somebody's workflow. You've changed, if they're used to seeing pulse on top and SpO2 down below and heart rate, and those sorts of things in an order, if you switch up that order, that's a problem. So a big part of it is getting the industry to change, getting them to use something that's good, let alone showing that it's more efficient, more effective, better healthcare, and that sort of thing. It's about changing the way we practice.
Yeah. And I want to add, add to that for a second, because I think radiology is kind of a great case study in kind of adoption of AI and the way, they were scared of it too in the beginning, 10, 15 years ago, they were very fearful of it as well. They thought it was going to take their jobs away, things like that. So it kind of got brought in kind of on the sly a little bit by being workflow simplification and doing things that were monotonous to them and were taking up a lot of time, particularly on complex radiology cases. And so starting there and kind of simplifying their workflow, and that got fairly good adoption, and then kind of moving from that point and starting to get the AI in. So it kind of backdoored its way into radiology, and the radiologists didn't even realize that it was AI that was doing it.
And as we said, it's because in the end, the radiologist still feels in control of making the decision.
Absolutely, absolutely.
And so how that will work. But I do think some of the issue is, yes, we need people who are more comfortable with technology. Younger people or older people who are comfortable with technology. We need people who are comfortable with technology to be the leaders, to to support the use of these tools and to show the broader community how they positively impact, whether it's cost of care, flow of care, the amount of patients people can see. You know, we're facing a crisis in this country, if people haven't heard about it, of caregivers. Lots of people are leaving the professions, nursing in particular, but physicians as well. We need to have tools that will enable the people who are working to manage the patients that they need to see. They need these types of tools in order to take care of people. So where on one hand, we're giving them a lot of more information than they ever had, we have to give them the tools to manage that information and manage it over large numbers of people so that they can appropriately care for the populations that they're charged with. It's a real challenge. It's a real
I'd
challenge.
like to, if I could build on that for a second, because there's a newly published book, and I saw one of the authors at HIMSS, and so I bought the book right away, and it's called The AI Revolution in Medicine. I thought, God, this is great. It's brand new off the press. I'll learn everything I need to know about that. Well, there's for a techie, there was precious little technology in it, but they made a bunch of points showing examples of GPT-4, which is beyond Chat GPT, and it's the latest. And they highlighted the areas that you just talked about, which were, you know, what can it really do and where are the places it's first going to get into? And almost all of them are efficiency. It was answering medical questions for patients, for doctors, summarizing reports from medical records or literature. The amount of literature that's generated is huge, and making sense out of it for clinicians is a huge problem. How do you stay current? The other, clinical decision making or documentation of the results, that starts to edge into, we're going to help make decisions and we're going to do that. And the last one was educational materials specifically for addressing the shortages as well. So all four of those areas where I expected to see, we're going to do all this marvelous stuff with AI and machine learning and all of that. When you looked at it, the places they were seeing it that were going to be most effective earliest were in the areas of efficiency, improving the practice of medicine from that perspective, let alone letting some machine somewhere automatically operate on you, diagnose you, and do all of that. So I thought that was really interesting, because it's an eye-opener for me as a technology guy, that really the benefit in this is the efficiency of getting people in and out of the process and moving it through.
So
I just want to add,
we're gonna have one comment, then we're gonna call time, and then we're gonna go off the record.
Okay, I just want to say one fun thing, and that is there are some people who think robotic surgery is actually a robot doing surgery. It's not. It's a surgeon sitting at a console using a smaller scalpel, a smaller whatever, controlling it electronically, but the surgeon is still doing the surgery. So if somebody tells you can have robotic surgery, don't get worried. It's not, no robot is doing the surgery. The surgeon is just doing it more remotely so they can do it with smaller things, make littler incisions and not big scars and things like that, and do it more delicately. So not to worry, the robots have not taken over the world.
I was thinking about that when Bill was saying changing physician practice, because in the early days, they had to do it backwards because they were doing it on camera, and they had to learn how to do right to left and left to right. So interesting. Nice to end on the recorded part on this.